Thank you, everyone, for joining us today for the next event in our AI in Action series. AI in Action Practical Applications for Safety Net Providers is a monthly Zoom series that is co hosted by the Center for Care Innovations, Health AI Partnership, and Alliance Chicago, that is dedicated to exploring research and implementation of AI based solutions that address the unique challenges and opportunities within federally qualified health centers and other safety net healthcare delivery organizations in order to promote equitable access and improve patient outcomes. So today we will be talking about practical advice for AI product due diligence for safety net healthcare with Scott Serpa from the Coalition for Orange County Community Health Centers. Go to the next slide. Just so a few quick reminders before we get started today. Please make sure that you are on mute to minimize any interruptions to the presentation today. We will have some time at the Q&A at the end, where you can come off mute to ask questions. But you can also put questions in the chat box throughout, and we will get to those towards the end of the presentation. Just a reminder to also please disable any external AI note takers. We will send out a recording and summary takeaways from today's presentation within the next couple of days. So please disable those. And if you have any tech issues, Nikita Gupta from the CCI team is here to help, so you can message her. Can we go to the next slide? So just a few upcoming events to keep in mind. Our next AI in Action event will be returning in early August. So we'll take a quick break for that July 4th holiday, and we'll see you again in early August. CCI is also hosting their Safety Net Innovation Summit, which is themed around Wayfinders Community Innovation for Uncharted Times in October. Tickets are now on sale at CCI's website, so go ahead and sign up for that while it's open. This is where Health AI Partnership and CCI first really got to know each other, so we hope to see you all there. And Health AI Partnership will also be at the HIMSS AI in Healthcare Forum in mid-July with our representatives from the inaugural cohort of our Practice Network program. So we hope to see you there. If you attend, please come find us. We'd love to meet you. And so just a quick agenda for today. I'll be providing this quick welcome and overview of the presentation and upcoming events. And then I'll turn it over to Scott in a few minutes here. And we'll have some time again for Q&A at the end. So feel free to put those questions in the chat or to come off mute towards the end to ask those questions. And again, our topic today is practical advice for AI product due diligence for safety net healthcare. And we are excited to hear from Scott Serpa, who is an integration coordinator and data analyst at the Coalition of Orange County Community Health Centers. Scott has spent around 7 years developing data solutions in healthcare and has expertise in data science, artificial intelligence, and the nonprofit health sector. So we are very excited to have him here today. And Scott, I will turn it over to you.
Hi, thank you. Let me go ahead and share. All right. Oops, that's the side with my notes. Let me go ahead and change that out. Okay. Perfect. So, hi, I'm Scott. I've been working in health data for, as was mentioned, about 7 years, and I got a master's in data science and artificial intelligence, which I finished 2 weeks after ChatGPT released, which was a very exciting time to be in AI. I want to talk about my experience with that, working with people implementing AI solutions in the primary care space, specifically mostly with federally qualified health centers, because that's been my experience. Some of this information may also be applicable to larger health networks, but as my experience has been with smaller health clinics, I'm going to be talking about FQHCs primarily. I might reference a few studies throughout this, and if you're interested in reading any of those further, please feel free to DM me here, message me on LinkedIn, or just send me an email, and I'll send you those for further reading. So before we start, I just want to comment on kind of the relationship that we have with technology. I have a friend in Peru, and I asked him if he used this like kind of world-changing technology as it's been sold to us. And he said sort of maybe. He wanted to say that like the relationship that he feels that his culture have with technology is that it's never really made for them. Like it's just kind of something that's there, handed down to them, and they can kind of use the pieces and put together something that might work. And I feel like in healthcare, sometimes we have a similar relationship with technology where it feels like it's not always really made for us and our needs. And I just kind of wanted to make sure to highlight that contrast because it's going to strongly affect like how I view the best way to approach evaluating these services and the best way to actually use these tools to be most productive. So I'm going to talk about this session in about four parts. Going to talk about go through evaluations, the way that I see clinics using their evaluations, and then the way I think that like these processes can be improved. Going to talk about safety a little bit. Going to talk about some of the limitations that clinics have, especially those with less resources than some of these larger care networks, which is again where some of that uh, difference comes into play. And then I'm going to spend a little time on ethics. So first off, I just want to get out of the way the definition of what is AI. AI is artificial prediction machines. They're going to be these systems that you input a certain amount of information and then it will tell you either a categorical or a long string of language that's most likely as the outcome per the reward model. That doesn't mean necessarily it's most likely to be useful to you. It's just most likely to match the reward model, which again speaks to that difference between in alignment. So I do urge everybody to read some studies into interpretability. But one example of like a misalignment that I like to give is there was a AI model once that they tried to identify whether a skin condition, like a mole, was cancerous, and they found out through interpretability studies that it was really just looking for the presence of a ruler more than it was on any determinant like factor of the mole itself. So I'm going to talk a little bit about Gen AI and versus machine learning very quickly. Almost all this is going to be Gen AI. Gen AI is generally what's being most used at clinics. It has the highest interest right now, and there are the most products available for it. Machine learning has kind of easier to understand metrics a lot of the time, and I know that these definitions can be a little bit fluid, but hopefully, like this separation keeps it focused on generative. And I also want to say that not all generative AI is the same. Um, and that matters because without going over how each one works, calling everything AI can be confusing. There are a bunch of different types of them right now, like a difference between large language models and large reasoning models. If we don't understand what we're being sold and what's under the hood, we're going to make mistakes in how we evaluate it. There was a study from MIT that showed that reasoning models are much worse at low complexity tasks than large language models. And then they are better at medium complexity tasks. So knowing what kind of system that you are purchasing and what you're working with is going to affect how able you are to understand what the use cases are, when to apply those tools, and what those tools' limitations are. So with that, I want to get into the products nonprofit clinics are looking at, how they're evaluating them, how to improve that. At this time, I want to point out that there was a Fortune article I read recently that showed there was a report from IBM that only about 25% of AI initiatives delivered expected return on investment over 3 years. This is pretty bad, and these are often larger companies than a lot of the clinics that I'm working with. So it's important to kind of temper expectations for what an AI product can deliver at this point in time. But the need for evaluations is still very high. I disagree with this categorization that I find going around that AI is normal technology. I do think it needs to be treated a little differently because unlike other technologies, it's it's different from something like social media where the unexpected aspect is the human behavior, which is something we do have a lot of history understanding, even if we don't fully get it. Um, with AI, it's about machine behavior, which is something that's very new to a lot of people. There's a lot of risk with liability, and there's not a lot of laws and regulations that kind of keep that in check at the moment. So AI isn't quite like a normal technology at this point. So when clinics are generally evaluating AI, they follow this rough process. They gain interest in trying to adapt these solutions. They will evaluate the vendors, usually a handful of them compared side by side. They'll test it and they'll roll it out. And I've seen several different ones being used. I'm going to probably dance between talking about like different problems with ambient assist, which is, transcription into progress notes. I'm going to talk about translation, uh, and I'm going to talk about just plain ChatGPT because all the clinics have use all three of these and are looking at buying and integrating all three of those to better serve those purposes. I don't think that this process is necessarily like the best, and I'll talk about some of the strengths and weaknesses of it later and how those can be improved, starting with the interest. Um, Orgs can come to the conclusion that they want AI a number of ways. That same IBM study from earlier showed that despite only 25% having expected ROI, 85% of CEOs believe that this is something that's going to become uh, basically efficient and useful to them. And that dichotomy comes from a number of things, but generally what it comes from is that it's interesting and they want to use it. I think that this interest should be more tailored to what problem you want to solve and what solutions exist for it. So instead of clinics just saying, I think we should try to buy these tools because I think it would help with maybe this or this, they should come at it problem focused. And I try to, when I'm working with the clinics, say, focus on what do you want to solve? What solutions exist outside of AI, if any do, and are those better? And then what are the known outcomes of these solutions? If there isn't a known outcome, you have to kind of question, like, does it really solve my problem? Is this something I should probably be interested in? Uh, Now, for vendors, the way clinics go about this generally, they'll talk to a few vendors. They'll compare the information they receive. They'll say, I like this one. I like the output of that one. It's very intuitive. Um, the sales teams are, in my experience, having talked to a few, they aren't particularly knowledgeable a lot of the time as to what certain things mean when they're saying them. For instance, I'll talk about accuracy in a minute, but it is important because I did see an interview with one of the CEOs of a large ambient assist company, and he said that he built the first implementation of the system in about 4 hours. That means that you can make a convincing implementation of a system in 4 hours. Um, Now that company has gone on to, you know, significantly modify and enhance their system beyond that. But I do think it's important to evaluate vendors very robustly because this technology can be confusing, intuitive, and very easy to start up in a way that appears on the surface to be very convincing. So one of the questions I like to ask is, what is accuracy? Um, Especially for language-based problems such as translation or large language models for like writing emails, or if you're doing ambient assist once more, saying you're 95% accurate could mean a lot of different things. Is that 95% factual accuracy? It makes up things 5% of the time. When it's making things up, are you counting like just that one word that it made up as, 5% of the total? Um, and then if you are you including words like articles or conjunctions like that can just blast the number up, artificially boosting the numerator? So being able to answer this question is going to be pretty important for vendors, and I feel like it's really important to push them to give a really convincing answer because this is often one of the few metrics that people get when they're trying to buy these systems, and it's not particularly helpful a lot of the time, nor is it even comparable between vendors one to one. So some other questions I think that it's worth asking vendors is who makes these systems? What are their qualifications? You want to ask and make sure that these people are knowledgeable about both AI and the space they're developing AI for. You want to ask who makes the system? What is the system trained on? Is it an API wrapper? Are you using ChatGPT? Did you train it yourself? If so, how did you get that data? What does that data look like? You want to ask what are the goals of your software? What are your reward systems for it? How is it being improved? How is it being trained? And then a question that I think is really helpful to end on is how do you know when you're wrong? How do you know when it makes a mistake? Because sometimes it's not immediately intuitive. Sometimes things can just be like what the definition of a mistake can be complicated sometimes. And I'll talk to kind of differences in language that could be considered a mistake a little bit later. So for testing, most organizations right now, they're just kind of rolling out demos to one or two providers and they solicit feedback. This is like not a bad process. I think that intuition is pretty important as a measure. However, it's important to use that intuition to judge and not just to consider like whether or not passes a baseline. So you need to be like very critical, approach it like you're breaking down like a movie or something like that. Um, and I know that Kaiser recently published a paper on ambient assist specifically to show whether or not time was saved per appointment. If you're doing tests based on, whether or not you save time, that might be an interesting read. I think that they found that they were maybe saving single percentage points at the end of the day. So the indications are not promising if you're just looking at time saved as your main metric based on the existing data out there right now. So a better way to improve this and to bring forward some of these kind of elevate your testing process is again focus on having a problem. If you don't have an original problem to solve, or your original problem is kind of more trying to fit the technology than it is trying to solve an actual issue in healthcare and patient service, you're going to struggle to find a measure that is going to be convincing for that. So if you want to improve ROI, measure your ROI against implementation of healthcare. If you want to improve quality of care, measure your quality of care. You want to make sure that you're pretty holistic about it too. Make sure that no other areas are being sacrificed. And then you also want to make sure that when you're doing this, you are going to be able to attribute any of this explainable difference to the AI. So you want to do there's some statistic tricks to help with that. Um, why and how does it solve that problem? I think understanding some of that's going to be very helpful, but interpretability is always rough with artificial intelligence. However, if you're doing something like using AI to write emails, asking yourself like, why does it solve the problem of writing emails? Like, is it even worth writing? Is probably a good thing to start with. And then, of course, once more, apply your measures to your problem. So for implementation, clinics right now, and many in healthcare, once it's done testing, it's out. Like it's in the world. They're happy. It gets rolled out to, I've noticed about 50 to 75% of providers tend to accept it. The rest they choose not to, and they're given that choice. I do believe at this time the tech should not be forced on either patients or providers who are uncomfortable with it. I do think that after a long period of testing, if you do notice there's a benefit, you can come back to those providers later and say that, hey, here's all this evidence that suggests that this has been a net good. And we want to kind of bring you on to this so that everybody can benefit from those. Uh, if there is a benefit, which of course, not all cases there will be. That monitoring is going to become a really key part of expanding the current clinic's use of AI. Right now, as I mentioned, almost no monitoring occurs. You need to be doing constant spot checks, and you need to be constant checks for alignment, and you need to be evaluating changes to the system. There's this psychological effect that can occur. I like to think of it, it's similar to being on your phone while driving. which don't do, by the way, highly recommend against. But after, you're on your phone for like a week and then 2 weeks and then 6 months, and suddenly you have 364 days where you've been on your phone driving to work every day and you've never had an accident. So you think it's totally fine and you kind of just start to ignore it before suddenly hit by a car. This is definitely a potential with AI. You get kind of used to and familiar with it, and then you stop checking it as regularly. And this needs to be done at the implementation on an ongoing basis to avoid having accidents. So, regarding safety, AI has been around for a while in various forms, almost 100 years if you're just looking at the underlying math for it. We do need to look at potentially novel applications of AI because a lot of these approaches to using it in the healthcare space, some of them are more well researched than others. Uh, some of them are not. But we need to make sure that we combine our limited understanding of ourselves, the humans that it's affecting, and the technology itself so that we're able to utilize this at its absolute highest level. And I think it's important to say that AI does work. This is one of those things that makes it kind of difficult because it is functional, but it's functional at this time in the same way that like steroids are. You're going to see results maybe, probably, especially if you put in a lot of work. But there's potential for significant harm down the line that you might not be aware of. So, well, I want to talk about human in the loop. Human in the loop has a few flaws that we're not really talking about. There's at least one study that indicates humans and machines working together produce worse output than humans or machines alone. Human in the loop right now is used primarily for liability shields than it is for actually improving these systems. The California Medical Board, I don't know about other states, but certainly California has stated the use of these technologies and any potential errors are directly on the license of the provider using them. And that's in part because there aren't a lot of regulation laws or case history for suing a machine if something goes wrong. I also want to say that there's some other human behavior things. There was a another MIT study that found that if you tell people a bot is going to be a certain way or do a certain thing, they will treat it as if it does that thing. So if you say this bot is manipulative, people will believe it's manipulative. If you say it's good, they'll believe it's good. If you tell somebody it's a therapist, they'll believe it and treat it like a therapist. Um, this is not really helpful when you're trying to critically approach these systems, especially in healthcare, and for these smaller clinics that might not be aware of how much scrutiny to give these devices, especially when they're comfortable with the fact that a human is involved. They should be aware that that human might be less able to identify some of these problems according to the research that we have than you would assume. Normalization, big part of this. It's that same thing as cell phones and cars. Sometimes all it takes to make something true is to say it. There was a study that showed that using AI can significantly amplify false memories and witnesses. The AI was used a little different methodology than we use in healthcare, so it's not working as like an ambient assist or as an operational assistant. It was used as an interviewer, and I think it was like 1.6 times false memories or something like that. It was pretty significant. There's also issues in safety with censorship, bias, data gaps. Just making sure that when you buy a system, when you're using a system, implementing it to, write emails, write processes, or even like I've had one clinic tell me that they use it to write like medical classes. It's really important to understand the data gaps, biases, and censorship that's in the underlying program. Like, for instance, a medical class about uh, like the use of a medication might not understand that there's a difference in how that medication is processed between like men and women. For example, women have a lower metabolic rate than men. And so they might be giving advice from the wrong standpoint. And these kind of biases exist in humans as well, which is why they exist in AI, because they collect all of our flaws and then amplify and codify them. So I want to talk about the thinking versus administrative tasks. A lot of people talk about thinking tasks with AI. When you tell an AI, like, write a story for me, that's a thinking task. When you say write an email for me, that's a thinking task. Write a process for me, it's doing your thinking for you. I advise not doing that at all. I recommend, treat it administratively. Always have it give it more and then make it and then bring it down. So have it do more summary and then not ever create. That's a good way of thinking, like whether it's thinking or doing administration, is if you're ever asking it to bring new information in, that significantly increases the risk of violating safety of your patients and of the system. And also, I do want to point out that despite the fact that clinical decision-making AI is one of the most well-researched uses of AI in healthcare, it's also why no clinic that I've worked with has been interested in buying that. They're all interested in the transcription, the translation, and administrative and operational assistance AIs because it's seen as safer, which is accurate. So a lot of these limitations I want to talk about are going to be pretty straightforward, but they're issues I see as kind of sticky to overcome. What gets in the way a lot of the time is that people are busy. They're very, very, very at the FQHC level especially. You'll often have somebody who's just like cross-trained into IT or analytics, and they'll be doing this during the onboarding phase, and then they'll move on to another project. This is one of those things, when you have AI that's supposed to save you time, but then you have no time to actually do it properly. It doesn't help always. So another barrier is data. Um, Most clinics are buying things, they're not building their own. So like data cleanliness doesn't necessarily immediately seem like it's going to be a concern, but it is because if you don't have good data and good analytics capabilities, you can't measure whether or not something is working. So this is more of a limitation to the monitoring side of it than it is to building an AI system. I think that none of the clinics I've worked with probably have enough data to build their own from scratch. And certainly like the expertise to build their own from scratch. Uh, it's a very difficult problem, but I do think that this data barrier is something that probably if you're looking at implementing AI in your environment, you need to make sure that you have enough information and it's reliable enough to properly measure the effects of the system that you're buying. Talked a little bit about the knowledge gap. Um, AI is a little bit kind of a different beast. You need to know there you need to know how it works. And there's a lot of ways to acquire that knowledge. And I think there's a lot of really good training that's happening. And I think that training will be the way to overcome this, but it is going to take sustained effort over a long period of time. There's a lot of turnover at a lot of clinics. And if you turn over in the middle of monitoring some of these projects, it's very easy to let that drop off. So as a caveat too, I'll say that I've seen a lot of I'd say like I want to say opportunists in this field who are consulting, going around saying, I can help train you on AI use. And you just kind of want to vet those the same way you do vendors. Like, where do you come from? What is your expertise? Do you have experience in healthcare? Do you have experience in AI? Making sure they have both is pretty important when they're doing the training. Having only one or the other is going to result in some gaps. Now, cost is always going to be a problem with federally qualified health centers. A lot of smaller clinics are working very thin margins, but these AI systems are not particularly expensive a lot of the time. If you're using the smallest open AI system, your cost per provider per month, assuming 15-minute visits, 15 visits a day, will be about $30. And that is the baseline. If anybody's charging under that and they're piggybacking off of OpenAI, uh, that's a cause for concern. But I've seen prices 30 to 500, $600 per provider per month. So it's generally pretty affordable, more affordable than scribes. But it is something that is important to understand. I highly recommend that clinics who are doing this and looking at pricing these systems look up how these systems are priced, especially if they do token pricing. So you might ask, how is it easy to use being a limitation? Um, it's because it's easy to use, it's very confusing. So if you have a tone deaf friend who is singing for the very first time, and they belt out this entire song completely wrong, and they just at the end they say, "Oh, I absolutely nailed it," because they don't realize, like in their own head, they hear it all as perfect, and that's true. They said the words, um, they did it vaguely musically. It seems kind of easy, but there's a lot of room to grow, and I think that just because something is easy to use doesn't mean it's necessarily easy to master or it's easy to use well. And it can be very confusing to somebody when they think when you're like, well, I'm getting output that's like decent, so like why would I have to learn more? And that barrier to pursuing that extra knowledge is going to hold back a lot of clinics from achieving a level of uh, a level of AI use that is actually going to be production ready and result in positive outcomes. Uh, I want to also talk about some of the limitations with people. People who come to FQHCs and people who go to concierge medical are very different groups, and they are grouped together as one market. We're all buying the same products, and the our relationship with technology is different. People act differently when they're being recorded. This is something that's well understood in journalism circles, but it's not really as heavily researched in the healthcare field. So one of the things that I think is pretty interesting is that you have people, especially in healthcare, who are going to be a little bit more worried about tech, and that's going to hold back your implementation of these systems. You need to, I recommend, I shouldn't say you need to, but I recommend trying to train providers on how to talk to people when there's a microphone in the room. It is going to feel different to different people of different communities and backgrounds. So we need to be considerate of that and make sure that we're not just, forcing stuff on people without having an understanding of their feelings and the way that they'll change how they act in these situations. So I'll talk about ethics a little bit here just to round it out. I want to first share an analogy I read in Careless People because I think it really applies well to AI. Um, when Alexis de Tocqueville visited the US in the 19th century, he was on a steamboat that hit a sandbar and capsized, and he nearly drowned. Afterwards, he found the manufacturers of the boat and he asked them, "Why didn't you make the vessel safer?" They explained that technological innovation in America was happening so quickly, there was no point. By the time they made the necessary safety changes, the boats would be obsolete anyway. So it's better to take a chance on what you have. If some people drown, no need to dwell on it. You're safe in the knowledge that something better is just around the corner. I don't think I need to explain why in healthcare that's probably unethical. So one of the big things is goal misalignment. The people developing these tools, they're doing so to make money. That's not bad. It's just true. Uh, there's, and that doesn't necessarily misalign the goals either. But we do need to know that our goals of improving patient care and saving time on patient visits are not necessarily going to be optimized for the product. So I want to talk a little bit about what happens if you save a provider time, for example. This is a goal misalignment problem. If you save a provider 30 minutes a day, do you think that this 30 minutes then gets put back into time with the patients, or do they suddenly get two more patients added to their schedule? And according to, if we look at how coders at Amazon are being treated right now with optimization and use of AI, it's going to be the latter. They're going to add more patients to the schedule. So if your goal is to save time, but someone else's goal is to maximize revenue, um, you're kind of going to, you got to make sure that you find some sort of alignment there. Um, I think that people in general, they don't want to make bad technology. They don't want to be misaligned. There's a genuine, a lot of these things come from a genuine place of good, of a feeling of goodness. And so it's pretty important to make sure that we fix this problem before we make it someone else's problem, I guess. Because everybody involved does want to fix this. And so having conversations about this early on is going to be very, very helpful. So I also want to talk about efficiency. It's not good all the time. I think efficiency has like this kind of golden glow about it. But I want to give an example of the best way I've ever found to improve patient numbers, which is you give everyone an aspirin and you kick them out in 15 seconds. Your ROI is incredible. Your patient numbers are going to be fascinating, just beyond anything you've ever seen. Um, your health metrics are going to suffer a lot, but that's not what you're measuring. You're measuring efficiency, right? So you got to make sure that when you're doing this, you have the outcomes that are intended, and I mean like all of the outcomes that are intended. You don't want to just focus on one thing and sacrifice the others. This is really important for when you're doing your testing, that you don't just like narrow in on having like a high accuracy system, because potentially you'll get there, but it won't be beneficial. Uh, I interviewed a medical scribe for this, and he had mentioned this interesting story about how sometimes these doctors in ERs are motivated to rush. He was told one time, do not write down that this patient is experiencing abdominal pain, because then we have to go and do all these treatments. And the doctors get reduced salary and increased risk of layoff if they don't hit these time numbers. So there's motivation there sometimes in these systems to kind of take shortcuts and do things. And we don't really understand what that's going to look like if everything's being recorded, because they're still going to have those motivations of, I need to save time on a patient, but the way they go about that might be more or less harmful. It's just an important ethics question to understand that. There's also the loss of iterative learning when you're overly efficient. The process of writing something will inform your thinking about it. Uh, like when you're writing an email, instead of having an AI write an email for you, or when you're writing a process for healthcare, or when you're writing a class, you want to say things like you want to say things like, you know, as you get through your first couple sentences, your conclusion might change a little. You sometimes will go back and revise the whole thing. You'll have a new idea. Sometimes solutions will pop out of nowhere as you're writing the question. And we're robbed of this experience when we make this all hyper efficient. Um, it's just the way human brains work. And it's not a problem that AI is equipped to solve. The other side of it is people are uncomfortable and we shouldn't push it on them. Would I want AI to be used on me medically? Probably not. I don't think that, I think that like we all kind of accept that when we go into like a doctor's office, we just kind of trust that the doctor has our best interest and does everything correctly. Uh, and I don't necessarily think that we can apply that same trust to machines, especially with how little we understand about how they interpret information and give it back to us. Um, this personal choice kind of comes from a quote that I heard from somebody I unfortunately do not remember the source of, but they said, would you fly on a plane that carried the motto, move fast and break things? Uh, AI is racist. This is very well documented. I don't feel like I need to go into it too much. And it affects us in ways we don't fully understand. It's been linked to addiction, loneliness, radicalization, and suicide. It can reinforce societal biases, cover up data and personal knowledge gaps. It can push unknown and unknowable agendas because interpretability is still an issue. I did hear about a story who reached out to a friend of mine who is a ethicist, and they were the head of an engineering department at a university, and they said they were concerned because they wanted to make sure that they were not the one who developed the next microplastics. So in conclusion, there's a lot of potential. It's fantastic at certain things like remembering certain words or concepts. It can bring down the cost of screenings for diseases. It can improve care. It can save providers time. It can improve quality measures. It can improve the amount of things that we can do at point of care and primary care. We can suddenly, if we have the right imaging programs and the right, um, you can do a lot with a camera, and that would normally require a specialist referral. It can save a lot of administration time. It can improve the skills and quality of the people in administration to allow them to do more with less. But there's also this potential for great harm if it's not mitigated. So knowing how to recognize the strengths and weaknesses of the AI that you're looking for and how to best implement that into the space you're working in is going to become very, very, very important. And making sure that you understand some of these ethical issues is going to become very key in making sure that we do this well, and we're not we don't do social media 2.0, I guess. So thank you.
Thank you so much, Scott. That was an amazing presentation. I wonder, Nikita, we know we have questions. I know that we have a slide, but it does already look like we have a couple of questions. But before I get to the ones here, I know that we had asked in advance of the registration a couple of questions you all had. One of the questions that I wanted to ask you, Scott, is, how do we find and vet the safety of AI tools? I mean, you shared a lot of different ways in which that can be done, but would be a really great way in terms of responding to that very, very important question.
Yeah, honestly, it's going to be hard. I think a lot of the responsibility for the safety is going to fall on the people developing it, because there's so little we can do to understand as users to understand what's happening underneath these systems. Um, and so I do think that unfortunately we don't have a lot of power for that. What we can do is just push back very hard and say, like, listen, we in the FQHC world, I know that we have a lot of people who are immigrants who come from certain communities, and the language that they use is not necessarily the language that's coded into these AI in a way that results in the best outcomes. Famously, like, AI is really bad with black speech. Um, but yeah, so I think that, like, it's going to be just we need to understand the limitations, and then we need to push them to better solve them.
Thank you so much. I'm going to raise a question here from Candice. Can you talk about the risks of wraparound AI products when the underlying AI technology changes? She also asks, how can those vendors mitigate this risk? And how can you ensure a vendor you're evaluating is continuously monitoring and mitigating these risks? So it's a really similar
Yeah.
but important question.
Yeah, so these like call them API wrappers. These products that use something like ChatGPT and then feed it through a process of like a bunch of different prompts or fine tunings, or just some sort of information injection. Uh, these risks are like fairly, when you have an underlying model, it's really, 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 mm, whatever the opposite word of robust is. I can't remember right now. But it's very bad at adapting to change. Like, so one example you can do is you can download a bunch of small models on your computer, like just download like Mistral, Llama, um, DeepSeek, and write like some prompts and just say, like, I want you to do this, and then change the underlying model, but keep all of those same modifications and prompts results. And that technology changes and update, companies to basically rewrite everything they do, and there's still no way to be consistent about it. So when you have these ongoing monitoring, and the way to mitigate this is you need to have a relationship with the vendors to know, like, do you ever upgrade your system? When do you upgrade it? What's your process for this? And that's going to help protect you against some of the problems with that.
So a lot of this is really doing due diligence with those vendors that you're entertaining before making that decision.
Yeah,
Um,
and maintaining that ongoing relationship of pushing back for everything.
right. I'm going to raise a question here from Tiffany. Are the ethical issues such as racism because of the training sources used or other training mechanisms, or is there a different causative factor?
Yeah, I think that the mechanisms are probably not necessarily the issue, but it's just that humans are racist and this is trained on humans. And it's not something that like we can solve necessarily. I was at a journalism seminar and there was a thing about like how communities use languages differently and how we need to be sensitive to that. And like one thing that like is kind of potentially like racist, but wouldn't necessarily seem that way, which is why it's hard to detect bias sometimes, is if somebody comes in and they're expressing a very personal condition in a language that is comfortable to them, and then an AI summarizes it, but just changes the words to match medical speak. And then the provider a week later has a follow-up and doesn't realize that they needed to use this more sensitive language. Uh, these are the kind of things that can like kind of come out with even the most simple systems. But yeah, there's data gaps as well. Like we simply like I heard recently that like birth control is tested on men primarily. I mean almost all medications are. So this is one of those things that like AI just absorbs and treats as normal because to the AI it is normal and it doesn't understand that there's a problem with that.
Thank you so much for expanding on that. I'm going to raise another question. I will just read it out. I don't want to mess up anyone's name. Where do you find validated known outcomes for an AI tool of interest, and how do you assess, validate those established outcomes?
It is hard. So there's an LLM leaderboard, and that will tell you like for the top language models. The problem is that it's very gamed. Like Meta released a model recently, and the model that the public received was different from the one that was being evaluated because they had access to the leaderboard to just keep submitting models till they got a high number. That's something to be concerned about for vendors as well. Sometimes or I can't say sometimes this happens, but the motivation is there to use a powerful model for their metrics and then give you a cheaper model for continued use. I don't see this happening, but it is something to be worried about. So I guess to answer the question of where do you find validated known outcomes, it's really hard because any system of measure is going to be like abused by these systems are really, really good at targeting measures. Like that's their whole purpose is to be able to succeed at like specific predictive tasks. So if you have something that's like a Q&A board, it's going to be very good at like targeting specific answers to those questions.
That's really helpful. I'm going to go back to, again, a pre-populated question here before going to the chat again. How can we understand, as it relates, again, there's so many vendors out there, but from what you're seeing and can share with us, how can we understand appropriate pricing for these vendor solutions? Since you mentioned a lot of the safety net really is purchasing more than they are building, but have you been able to understand or ascertain what appropriate pricing might look like within the safety net?
Yeah, it's hard. I mean, so if you know the underlying model, you can look at their pricing structure and you can just do what I did to get like that $30 number, which is you put in how many providers, how many minutes for a visit, and you look at like the cost of transcribing from text to voice, and then the cost of the input tokens to take that text in, and the output tokens to summarize it. And then that will give you kind of the baseline. And then you can look at like what a company's pricing model looks like and see if it lines up with that. Some of them have, they target enormous profit margins. Some of them work at a loss. I think that working at a loss is a bit of a risk because You don't want to get reliance on a system that's not stable or could potentially double or triple in price in the next couple years, which would significantly affect like your ability to operate if you're working on narrow margins. Hopefully that answers it.
No, it was a great technical response, and I wonder how folks might be able to do that. But I think that's a great place to start. I'm going to go back to the chat here. Scott, given your role, what are the major challenges in integration with vendors, and what are your suggestions given what you've seen?
Yeah, so I talked a little bit about like some of these limitations, but like so far the greatest one I would say is simply that like the people who are vetting these systems are not really well equipped to understand the best way to vet them. And some of that is just, when you get your training on like Reddit and YouTube, you get a lot of misinformation that isn't really, it's really hard to debunk. Um, Especially if you're not very well equipped in understanding and using some of these systems. These systems are persuasive. They will tell you things about them that are not true. So if you like ask a system and say like, well, are you biased? It's not going to say, well, sometimes it will say yes, but it won't tell you how. And it won't be able to. So I think that like some of the major that's going to be always the major challenge is just like we have people who are working with these who are susceptible to the psychological manipulations and are not equipped to really push back on that, um, and understand that they are being, um, and to do the technical side as well. um, it takes a lot of energy to be able to like kind of balance all those things together.
That's super helpful. I'm going to see if there's any other additional questions. And while I wait for that, maybe giving it a minute or so, I did want to drop a couple of resources in the chat. Two things that you really touched on at the beginning, Scott, was this idea of focusing on what is the problem that you're trying to solve before running out and kind of, having an organization purchase a product. So really having that is something that I wanted to highlight from your presentation. I know that Health AI Partnership did develop a toolkit around like the 8 decision points to consider while implementing AI. And then the other was around that Kaiser research piece of like what they're learning and seeing, again, what they've learned from that implementation. So I want to put that in also a couple of vendor landscapes in terms of like what's out there. So that might be helpful. But I wonder if there are any other additional questions from the audience, if they want to put it in the chat or come off mute, you're more than welcome to.
Hey Scott, this is Candace from CCALAC. Just wondering if you have any advice, because I know you mentioned a lot of times they have the salespeople talking to the health centers, and they themselves don't often understand what they're actually selling.
Mhm.
So, what tips do you have if you are forced to talk to a salesperson on getting through that and getting the answers to your questions?
Um, if they're not answering your questions, you shouldn't buy the product. That's pretty as simple as that. Like, they're not going to change their model unless they stop making money doing it. I think that like there's definitely the capability. I've talked to engineers at a lot of these companies. You can ask to speak to an engineer. You can ask to speak to somebody who is able to kind of answer some of these more technical questions. I've had mixed success in actually getting a lot of that. But they'll generally be pretty willing to work with you and address those problems. But if they don't, unfortunately, it's probably better to move on. Uh, it's not worth the risk. And like I said, ongoing relationship with a vendor is really important for these systems. So if they're not even if before the sale they're not being very responsive and helpful, there's no shot that they're going to be a good partner moving forward.
That's really helpful. I want to just thank you so much, Scott. This has been an amazing presentation. Thank you so much for sharing your insights and again, things that we within the safety net are looking at and kind of also sharing your personal perspective. I did, before I pass it over to Sierra to close us out, I did want to drop one thing that would be helpful for this audience to know is that there is a healthcare AI bootcamp that is taking place as part of a national collaborative. And I just wanted to highlight that for all to see so that they can access it as well. So with that, again, thank you so much, Scott, for your presentation. And I'm going to hand it back over to Sierra.